IASNM welcomes you on the Nuclear Medicine and Molecular Imaging live webinar series. It is now my absolute pleasure to introduce Dr. Ameya Asarkar today. He is the Assistant Professor of Head and Neck Surgery at LSU Health, Shreveport, Louisiana, and he is the Acting Chief and Staff Physician at the Overton Brooks Veteran Affairs Medical Center, Shreveport, Louisiana. Dr. Asarkar completed his medical school and residency in India and a head and neck reconstructive fellowship at Tata Memorial Hospital in Mumbai, India. He then moved to United States in 2016 to pursue an advanced head and neck surgery fellowship at LSU Health, Shreveport, Louisiana. And then he stayed on as faculty at LSU Health, Shreveport. His clinical focus includes the entire spectrum of head and neck surgery with specific interest in endocrine and transoral robotic surgery. Dr. Asarkar's current research interests include clinical outcomes and cost effectiveness of treatment strategies in head and neck cancer patients. He has published several peer-reviewed papers and book chapters. Dr. Asarkar is actively involved with the American Head and Neck Society and American Board of Head and Neck Surgery, and he serves on multiple national committees. Dr. Asarkar.
Well, thank you, Dr. Mazar, for the kind introduction. Once again, thank you for inviting me today to talk on one of your, as a part of one of your webinar series. Thank you again, all the society members, for having me. I'm going to share my screen now. Okay. My topic for today is the role of PET-CT in head and neck cancer patients. Me as a head and neck surgical oncologist, our perspective towards this. Now, while doing this talk, it was a little different from my other talks because I'm speaking about nuclear medicine tool to people who are more familiar with it and are more experts in it than me. So with this talk, what I'm going to try to put across today is what are we as surgeons, as clinicians, looking for in a PET scan result, or what for us is going to change our treatment algorithms or influence the survival of our patients. So no disclosures for me today. So as I said, the objectives of my talk today are what are the clinical implications of using PET-CT in the workup of head and neck cancers? What is its role in the clinical implications to detect regional lymph node metastases? And this kind of like piggybacks on the first objective, but in my talk, I'll tell you why it's more important as well for us to know what the lymph node status of these patients are, and then to understand what the utility and the timing of getting a nuclear medicine scan or a PET scan as a post-therapy assessment. So by and large, we all are familiar with the importance of having PET and PET-CT both in the management of head and neck cancers. There's enormous literature as to how helpful it is for us at different stages of the management of a head and neck cancer patient. And then fused PET-CT images are certainly more superior than just PET imaging. And it helps in identification and characterization of right from the primary tumors, the nodal disease, and more importantly, as listed mets, because that influences how the prognosis of the patients is going to be. And then again, literature has shown that PET-CT actually alters therapy in up to 18 to 20% of patients when compared to management plans based on PET alone. So as I mentioned, I'll break down this talk into a few sections. The first one would be, what is its role? What is the role of a PET-CT in the initial clinical staging, both for primary and the neck? Second, the unknown primary, or where the primary is not found after a workup using the conventional imaging modalities, clinical examination, imaging modalities like CT, MRI, and thereon. And then in clinically N0 patients. What I mean by N0 patients are patients in whom clinically or even radiologically, we are not able to find any lymph nodes in the neck. Now, I won't go into the too much details of the clinical aspect of this, but there are various studies that have looked at patients when they have lymph node metastasis in the neck. It upstages the disease, and that also adversely affects the prognosis of these patients. And then the utility, as I mentioned, of the PET-CT in the post-treatment. So moving on, first and foremost, what is the role in the initial clinical staging and treatment planning? Does PET-CT influence the treatment planning, or does it influence the staging? So one of the recent studies, it was a multi-institutional trial, or the Akron 6685, that actually looked at, it was one of the first ones to look at the lymph node patterns based on the PET-CT in specifically, as I said, N0 patients in whom you are not able to detect any lymph node metastasis. And as we know that they reported the findings from around 240 necks from about 200 participants, pretty large number, good sample size. And what they compared was how did the visual assessment of the negative predictive value. We all know that the negative predictive value of a PET-CT is pretty high. I mean, upwards of 90%, 95% or thereabout. And they found that in both situations, whenever there was a visual assessment, it's very close to 90%. And as you see in the other table on the right, it's when you consider the SUV max, and we'll get to that, the importance and all that about the SUV max, but they saw that it was pretty similar, pretty high, even when the SUV max cutoff was around 1.8 and thereon. They did a good job at differentiating at different levels what the negative predictive value is, but by and large, it was pretty high. Now, they also looked at what was the false positive rate. It was around 10%, with the highest was at the level 2. These levels are basically the regional lymph node levels, which we anatomically divide them into. And the important significance of this is that all head and neck cancer patients, usually depending on what the subsite is, be it the oral cavity, be it the thyroid, be it the larynx, they have a kind of a fixed pattern of spread. And that is more important to us, because then when we treat these patients, be it surgically, be it with radiation, we need to address these lymph node basins. And so they did a good job at looking at the cutoff max, SUV max cutoff of 1.8, what levels was the false positive rate. And again, this false positive rate could be because of inflammation, could be because of previous therapy. But it's important to know what levels could possibly be false positive on a PET scan in N0. Now, how does this all translate clinically, right? Like, because we all want to know what the treatment plans would be. And then when we counsel the patients, we want to explain to them how these findings are going to affect us, how it's going to affect our treatment planning. So what they saw was the post-CT surgical treatment plan changed in about 20%, more than 20% based on the PET-CT findings, which is pretty significant. Now, they also further went on to dissect or do a subset analysis of these patients. The patients in whom these plans changed, there were additional lymph nodes that they were addressed. So to put it in perspective, say the initial planning was just to address the levels 1 to 3. They probably added another level 4 because they found uptake in level 4 lymph nodes. So what they concluded was that PET-CT may assist the clinician in deciding the best therapy for clinically N0 neck in head and neck squamous cell cancers. Now, at this point, I would say that this comes with a caveat, right? Like, because we are now looking at this paper based on the PET-CT findings. But when you look at the other surgical literature, there still are papers which are already level 1, which have actually looked at the survival of these patients. So that is what we want to look at. But But at the same time, given this paper actually gave us a new direction for future studies, I would say, to look at the survival or how these patients do when the plans are changed. Now, a follow-up analysis of the same database was published last year. And again, as they said, what they concluded was this study gave the specific patterns of metastatic spread in the N0 necks, and that could possibly help the surgeons to better plan neck dissection. But again, as a surgeon, as I said, there are certain there's enough data for me to go ahead and do a particular type of a neck dissection, regardless of the PET findings, if I would say, because we still have level 1 data in the clinical settings, which have actually looked at survival and how these patients do based on neck dissection. So at this point, I would say for initial neck staging, the PET-CT will not influence the decision to plan the extent of neck dissection, I should say. But surgical oncologists can use this data to a certain extent, especially those patients who have not undergone a neck dissection. So the pathologist does not have tissue to give us the exact results of if those nets were truly positive or not. For them, to a certain extent, a PET scan as an initial staging can help to plan their treatment or the fields of radiation, so to say. So what do the guidelines say, right? We all in today's world, it's all about evidence-based medicine. It's all about personalized medicine. So what do the guidelines say, and where does PET-CT fit in the whole algorithm of initial staging of head and neck cancer patients? So as you see, that PET-CT is associated with high sensitivity for both nodal and distant metastases. So by and large, for distant metastases, for staging, certainly a PET-CT is absolutely important. Now, again, even they acknowledge this, that radiation therapy may, with a higher sensitivity to find these involved nodes, it would be helpful for them. However, a PET-CT cannot rule out distant metastases. So for patients with mucosal melanoma or neuroendocrine tumors where the brain metastasis role is too high, we actually then have to offer them MRI brain to rule out the metastasis before staging them. So, in a nutshell, before we move on to the next section, I would say that for initial staging, for the lymph node status, PET-CT would certainly help us to know if there truly is a lymph node uptake or truly a metastatic lymph node, which we should address. But would it change my plan at this point? Probably not with the available data. And to say that with data available in the surgical field, in the head and neck world, there's enough surgical data for us to address the neck even without a PET scan per se for that reason. But for initial staging, distant metastasis, absolutely. With a very high negative predictive value, absolutely PET scan is indispensable for distant metastasis. Now, moving on to the second section of the unknown primary. As I said, approximately 3 to 5% of our patient population will present with initial nodal metastasis and an unknown primary of head and neck side. When I say unknown primary, it means that the lymph node, the squamous cell carcinoma that was diagnosed in the lymph node has a primary from somewhere. It could be the oral cavity, it could be the tonsil, but it is so small. It is so small and minuscule that routine imaging has not picked it up. So what happens in this case is, where does PET-CT fit in? Because PET-CT has, as you said, a very high negative predictive value. If the PET-CT is negative, truly negative in finding the oral cavity or in the oropharynx a primary, then you probably have to just address the neck and the treatment plan change accordingly. But if does pick up, or if that does pick up those small primaries, then we still need to go ahead and prove that that's truly a squamous cell carcinoma. So that's where a PET-CT helps us, because and this is even like what the guidelines say, that the PET-CT should be ordered before any biopsies or tonsillectomies to find that primary, and thus focused intervention can be given to that particular area, so be it surgery, be it radiation. So in our treatment algorithm for a lymph node, a PET-CT is probably one of the first investigations that you do, and then plan the treatment accordingly. So what is the rationale behind doing this? The rationale is that most of the malignant cancers have increased glucose uptake or glucose metabolism, and that helps with the commonly used radio tracer, and which are basically FDG avid, and to get PET-CT, it just makes sense to do that. And it also offers a high lesion to background contrast, which makes it a potential and a more sensitive imaging modality than the traditional ones. So again, there was a paper that actually looked at what is the sensitivity and the negative predictive value. And as we know, it's very high. The sensitivity is, again, closer to 90%, and the negative predictive value when compared to conventional CT is pretty high. And this is true for the primary as well as the cervical lymph nodes. So the next thing is always in this today's world of where economics of medicine is so important with the healthcare costs increasing. We did a study a few years back in our institute. Now, as I said, for an unknown primary, what we do is that the gold standard is to do a triple endoscopy, or what it means is take the patient back to the OR, and under general anesthesia, look at the most common sites in the oral cavity, oropharynx, be it the airway, be it the larynx, the hypopharynx, and see if you can possibly detect any primary site of or primary focus of the cancer that has spread to the neck nodes. So triple endoscopy means do a laryngoscopy, do a bronchoscopy, and do a esophagoscopy. Now, all this, although it's probably like a one-hour procedure, but it's still putting patient under anesthesia. That increases risk to the patient. It increases healthcare costs. So what we did was we went back and looked at our patients, around 23 patients retrospectively, of which 11 of them had a negative scan. And a pan endoscopy, or the triple endoscopy, identified primary only in one patient. Now, this translates into, as I said, the cost of pan endoscopy with pathology, because you're going to send frozen sections during the procedure. Look at the Medicare reimbursement. So it's a difference of about $400 to $500 on each patient, and these are all 2011 rates. So this could be more now. And the Medicare reimbursement for a PET scan is around $2,500. So to say that pan endoscopy is not required at all is wrong. But then what we can do is we can choose those patients accordingly. And if the PET-CT with such a high negative predictive value is more safer option, even in terms of reimbursements or even in terms of patient complications or the risks from a procedure, you may want to consider what other alternatives are available in such patients. So in a nutshell, again, regarding the unknown primary, PET-CT is certainly the very important investigation, one of the first investigations that you would do after a biopsy from the lymph node. And then all other scans are negative, is to get a PET-CT and direct your treatment accordingly. So this brings us to the next section as to what is its utility in post-treatment and how does it translate into survival or cost effectiveness. So going over what the guidelines or what the algorithms are, we typically use the NCCN guidelines, as I mentioned before. It does give PET-CT an important role. If there is an obvious disease, you really don't need a PET-CT to tell you that the uptake is there. Then you certainly need to get a PET-CT to make sure that there's no distant mets, but not necessarily for finding or proving that there is uptake in that area. Now, the response assessment is what we need a PET-CT for in these cases. It could be a partial response, a complete response, but to assess it. So this is where the PET-CT comes into picture. And as we say, like needs to be at least 3 months out, because there are again studies that have looked at if you're doing a PET scans too close to completion of, say, radiation or chemotherapy, there are high chances of more avidity still there, which could be post-treatment or inflammation. So 12 weeks or 3 months is usually the time when we get a PET-CT in post-treatment response. So what are the studies that I've actually looked at? So this is a large study with around 1,500 patients where they analyzed what is their rate of using PET-CT or what are the different modalities to get a surveillance or a post-treatment scan. So in the first 24 months and the second 24 months. So what they found was if the surveillance or the post-treatment imaging is in an asymptomatic patients beyond 2 years has a very low yield. And so you basically just need a first post-treatment scan at 3 months. And if the post-treatment scan is negative, then you can actually avoid getting subsequent scans unless the patient is symptomatic or unless there is a very high suspicion or a biopsy proven mass that you're suspecting. So again, you have to really personalize these studies based on the patient, each patient, and the physicians need to be cognizant of this. Now, there was another systematic review and meta-analysis that actually looked at the diagnostic accuracy in residual settings or in recurrent settings or post-treatment settings. And as you see, that the specificity is pretty high when the imaging modality is PET-CT, right? And then also they went, and this is the point which I made, the specificity and the sensitivity are lower when the scan is done before 12 weeks and after 12 weeks. And that's the same in nodal disease as well as the primary side. And in fact, the specificity, if you are doing it about more than 12 weeks or more than 3 months, is pretty much higher when compared, significantly higher when compared to doing it before 12 weeks, or very close to the therapy. So to sum it up, a whole body PET imaging should be performed in all patients within 3 to 6 months. Around 3 months is usually the time which we get a post-therapy or a post-therapy assessment scan. Because any positive scan at this point always has like a poorer prognosis. A surveillance imaging has a much higher negative than a positive predictive value. And this has been shown in multiple studies as well. And currently literature does not support any further scan after the initial post-treatment scan unless there is a biopsy proven disease or an obvious recurrence or residual disease. So another systematic review, and then coming back to my point of very high negative predictive value for even post-treatment settings. And again, these all studies are again reiterating pretty much the same, because it's very important to catch these patients early in their recurrent stage, if at all, at 3 months or something, before the disease progresses to an inoperable or unresectable stage from surgical standpoint. Because once they have received radiation, they cannot get any more radiation in such a short period of time. So we have a very short window, and of diagnosing these recurrences. And at the same time, we don't want to put patients through any additional procedures or unnecessary procedures. So that's the reason why a negative PET scan at 3 months is absolutely important. And one of the reasons they also mention about the reduced positive predictive value is most likely the post-treated inflammation and fibrosis. And the whole anatomy is also distorted in these patients. So that's one of the reasons why these positive predictive values are so low, and especially in post-treatment scans. So for us, a report saying that it could be inflammation, it could be but it cannot be ruled out. But a disease or a recurrence cannot be ruled out. It's always a dilemma or catch-22 for us, because then the whole further treatment kind of changes. You deem the patient palliative, hospice, or you can actually offer them any surgery, because as I said, any surgery in a recurrent setting is more morbid than what the first surgery was to begin with. So, and as I said, moving on to the next one regarding the neck dissection and an N0 and an N0 neck, they actually looked at, this is a very good randomized trial in NEJM that was published a few years back, and they actually looked at the PET surveillance, PET CT, just surveilling with a PET CT versus doing a neck dissection in these patients. And they actually found that the survival is pretty much the same. You do a PET CT surveillance or you do a neck dissection in patients after the initial surgery. And now with the role of like oropharyngeal carcinoma, which is exploding with the P16 status, there was no change. Again, there was no change before and after in terms of neck dissection, the survival. So what they concluded was that the PET CT guided surveillance resulted in fewer neck dissections, because before the guidelines were that even if there is an equivocal uptake on a PET scan as post-treatment, you would rather do a neck dissection than do surveillance, because these patients could still harbor some subclinical disease. But I think with this study, I think they have done a really good job at translating this this imaging modality into survival, because that's what we want when we consult the patients. What are your 5-year survival or 3-year survival? So they found that the survival, the 2-year survival was pretty much similar in both the groups, and the quality of life was also similar. And then they also looked at what is the cost effectiveness of this. And PET surveillance, when compared to a neck dissection, because all said and done, neck dissection still is a surgery. Patient has to be taken back to the OR. Patient stays in the hospital for a certain period of time after the surgery, and they saved like around $2,000 on every patient. Now, again, that brings us, this is a very good study as compared to what I said before with the Akron study, in a sense that with this study, I can actually have numbers in front of me to consult the patient. And depending on what the current data is, what current level 1 evidence is, I can address it with the patient when I'm counseling the patient accordingly. So this brings us to the next, I call it conundrum because a higher SUV value, because we all, like the reports that we get, we all first, like many times we look at what the SUV value is, because that's the only number that we can objectively see. So the first, we are directed first to looking at the SUV max. So why is this a conundrum? Because there are many times there are these benign scans, right? Like there's still uptake in some of the benign diseases, like if there is a tonsil, the tonsils will light up with a relatively higher SUV max. And as I said in my previous slides, in the Akron study, like the optimum cutoff for them was like 1.82. So anything about that, is that cancer? Is that a recurrence of disease? So that is the reason why we always like go back and forth with this. And in our tumor boards, we always have the nuclear medicine physician to tell us as not just about the SUV max, but what they feel or what their I would say a visual interpretation is as well, taking into consideration the whole history of the patient as well. Patient has undergone surgery, has undergone any radiation. So the SUV max is not the best tool, but still it's definitely by and large a higher SUV max has been associated with decreased survival or local control. But you need to also remember that there's a lot of variability and heterogeneity of these SUV values, because there's different protocols are used in different institutions. So that is why we always refer patient, or we always prefer getting PET scans from the same place or the same institution that we got the pre-treatment PET scan and then get a post-treatment. So you're basically comparing apples to apples and not apples to oranges. So again, this is like a small flow chart. I won't go into the details of the physics of this as to why SUV changes, but there are so many different variables that can affect the accuracy and precision of these SUV values. So there is literature actually that has looked at how does this translate, or how do these SUV max, or what is the clinical significance of the SUV max values. Now, again, as you see in this study, the best SUV max value that they used was 3.5. And then they modified it depending on the levels of these SUV max. And then the figures changed depending on how these cutoffs are. So how does this translate into clinical benefit, or does it influence the surgical decision? So again, the consensus of this study at least was that sensitivity is not high enough to replace the pathologic lymph node staging based on the neck dissection, right? So even if you have a higher SUV max, but if that lymph node is not a truly positive lymph node on a pathology, it won't change your adjuvant therapy. When I say adjuvant therapy, is like either radiation or chemoradiation. There are other clinical factors, there are other pathologic factors that we look at to determine that. So we are not there yet, but definitely an SUV max value is an important part of a PET scan report. So are there any objective criteria? Because we all need to talk the same language, right, across the board. So are there any objective criteria for PET-CT or CT reporting that can help us to bridge this gap, or to reduce the gulf between us clinicians and the reporting nuclear medicine physicians? So recently, and this American College of Radiology approved it, was the neck imaging reporting and data system, or the NIRADS as we commonly call it. It's like an interpretative framework that can be applied to any standardized institutional or surveillance imaging protocol, because that's, as I said, the role of PET-CT is even more so in post-therapy or post-treatment scans. So what NIRADS has attempted to do is it simplifies the communication between a radiologist and the clinicians. And then they have also given some guidance as to each level of suspicion, what the treatment could be. So that I will discuss a little bit in the next few slides. So this is a good flow chart, and they divided it between like the NIRADS of primary site versus a nodal site. Now, depending on what rate the categorization is, if it is just a diffuse uptake, then we just do a routine surveillance. If it is a focal uptake, you could do a direct inspection. And then if it's nodular uptake, then you do a biopsy. Now, again, they divide it into mucosal, superficial. Without going too much into it, the whole idea of bringing this up was NIRADS actually gives us an objective criteria or objective reporting to so that we can, without any even biases, go ahead and treat the patient accordingly. And again, this is the next flow chart for the nodal category. Again, like going from 1 to up to 5, depending on how strong the uptake is, and so on and so forth, because and then they compare it with the contrast enhanced CT scan, and if that is showing in a structural abnormality, what is the PET scan showing, and thereon. So this is a table of all the categories that are possible in IRADS. I think I misspoke. It's 0 to 4 and not 1 to 5. But again, incomplete, no evidence of recurrence, low suspicions, high suspicion, and definite recurrence. So what does the literature say about the NIRADS, or have there studies that have looked at NIRADS and compared them to other modalities? So this was a paper in 2017, which actually looked at the NIRADS and compared it to see if there is any inter-observer discordance, or if there are concordance. And they found that there was pretty strong inter-observer agreement when 2 independent readers read the scan. And definitely they looked at how it translates into clinical variables. So there was a strong association between NIRADS and recurrence, as we would expect, and a good performance in discriminating versus recurrence and no recurrence at the primary site as well. And then another study in 2019 that actually also concluded that there's a strong association between the categories of NIRADS and treatment failure at both the sites. So this is the reason I put this surveillance report template, was because this is very objective, right? Like, I mean, you just give a score and there is no chance of any argument. If it's a 1, it's a 2, and then we speak the same language as well. So it's a very important tool, and I think many institutes use it, some don't. So I think it would be a really great way to objectivize the reporting of PET scanning. And there's another criteria, the Hopkins criteria, which came out, and it's similar in terms of scoring. But what they did was they overall assessment score, and the highest score for each, the primary and the right neck and the left neck, was given on a score of 1 to 5, and with 1 being complete metabolic response, likely, and then probably likely complete, likely post-radiation, likely residual, and then residual tumor. And what they did was they used the patient's own uptake as a control, right? Like, because the uptake at the primary site was compared to the uptake into the internal tubular vein and the liver. So this is a picture how these the scoring system looks from 1 to 5, where it comes from complete metabolic response, possible complete, likely complete response to a positive disease or a residual disease. So we did a study and to look at the external validity of Hopkins criteria in our patients. So we included around 47 patients, and we saw that it still gives a very high negative predictive value when you have especially combined both visual interpretation and Hopkins criteria. And the sensitivity also increases when you use a combined modality. But we came across, like, we hypothesized that there were 2 missing links in the Hopkins criteria, because it does not take into consideration the development of new disease, which is pretty common, relatively common in head and neck cancers. And also it does not take into consideration, unlike disease, development of disease, which is unrelated to head and neck cancer, like lymphoma or any other kind of cancer that is not head and neck squamous cell carcinoma. So maybe in the future iterations of Hopkins, they may consider this, and further studies are required to validate these 2 points as well. But essentially what I wanted to put across with these 2 objective criteria is that criteria like these will help us to bridge that gap that we have and things that are lost in translation sometime, if I may put it, whenever there is a reporting from a radiologist or a nuclear medicine physician and us clinicians, and what actually translates, because ultimately it's about patient care. It's about how we counsel the patient as to what exactly is going on and what the further treatment would be. So to summarize for today, as I said, PET scan does not have a significant impact in the decision-making at the time of initial staging of the primary and the neck. And I would stress on primary and the neck and not the distant metastasis. Distant metastasis, absolutely, PET has a significant role. Then the next point is that at 3 months post-treatment, if a PET CT is negative, there is no data to get any additional scans unless the patient is symptomatic. And this also translates into like other issues in terms of insurance covering them as well. I think many insurance companies will not cover PET CT if the first CT was PET CT was negative and the patient is asymptomatic. Again, as I said, objective criteria for reporting like NIRADS or even Hopkins, it will help to bridge the gap between the nuclear medicine physicians and the clinicians. And in the absence of multi-institutional, especially prospective data, the use of PET scan or any other scanning for that matter should be a tailored approach with surveillance and with attention to other clinical pathologic findings like tumor type, stage, prognostic factors, and physical exams as appropriate. Thank you so much.
Thank you very much, Dr. Asarkar. This was an excellent talk and with a very broad overview about the head and neck cancer management. I'll open the floor for the audience for questions. And I have one question to start off Q&A session. So as you mentioned that the 3-month post-treatment PET CT scan has a high negative predictive value. So at your practice, do you also acquire a contrast-enhanced CT neck at 3 months?
So not typically, no. We just get a PET scan, and if there are any equivocal findings or clinically we feel that there's a strong suspicion, then we would get a CT. If not, then just a PET scan. Okay,
thank you. And that saves the patient extra radiation, I guess. And
absolutely.
Any questions from the audience?
If not, you can even type your questions if you don't have a speaker or something. But I do have a few questions or points for discussion, actually, either way, actually. So good talk, Dr. Asarkar. We like to know what our referring physicians feel the value for PET is and where they feel the most utility. Can you comment on something like, what do you expect from our reports? And in general, do we answer your clinical question, or do we meet the expectations when you see a report for a PET CT scan for head and neck cancer patient?
Yeah, so absolutely. I mean, as I said, like it's a vital tool, and more so in post therapy scans. What we would certainly like is if there is a more unequivocal result, right? Like, so everybody wants to know for sure what it is. So that will be first, but sometimes I understand it might get a little tricky as well for y'all. So I think a report that says something like clinically, like also takes into consideration what the history of the patient was, what surgery the patient underwent, something like that, and then a more definitive result. And then, as I said, if it incorporates one of those objective templates, that would be more helpful for us.
Okay. So one of our complaints in the field of radiology versus the clinical branch is we have to hunt for information for the history a lot. We spend like, sometimes a lot of time, and sometimes even then we don't have adequate history, especially if it's an outside referral from not within our system. Even if it is from within our system, sometimes the electronic records are not up to date, or it's not clear what the request exactly wants. So it becomes difficult sometimes to answer the clinical question. So what would facilitate us getting a better history in our requests from the referring physicians?
So again, I see your point, because we always have that communication gap. Sometimes the clinicians are these referrals are maybe put by the residents or the fellows, and then they would be like, they are just overwhelmed with their work, the surgical work or something. So they just say, hey, refer to a post-treatment PET scan. And that's it. That's all you get in the requisition. Yeah. But if there is something that is, say, built in the referring work queue or something, that, hey, these points are required, without which the order won't go ahead at all, or the consult won't go ahead at all. Maybe working with the IT on that might help to, I don't know, do you guys use like Epic for?
We at Emory, we are about to implement Epic right now. We do have an electronic ordering system, but it's the Cerner, not Epic. At LSU, I think it is Epic, and Epic has some tools, but the problem with Epic is it allows people to continue without filling most of those blanks. And so they, I understand sometimes the information may not be there, or there has to be an override, but an attempt should be made to answer most of those questions, because it is important. So for example, as you pointed out, most of the time we want to do a PET CT for response assessment at 12 weeks or 3 months after complete, especially after radiation therapy. Because of increased uptake that is related to post-radiation therapy inflammation. But sometimes when there is obvious clinical concern for recurrence and you want to go in and do surgery, you still get a PET scan before the 12-week time period, because the intent of that scan is to assess disease status outside the radiation therapy port, especially distant disease, because that would make surgery kind of moot, or that would change the intent of surgery from curative to palliative, right?
Yeah.
And so in those cases, we would allow to get the PET scan done around 6 to 7 weeks, so that you can operate by 7 to 8 weeks before fibrosis from post-radiation therapy would set in. And lots of times that is the information that we really need to hunt. And a lot of places do not have a physician or a resident pre-approving these scans. It falls on the chief tech or the tech supervisor or scheduling specialist, and they may not have this acumen to look at like what's the intent of the scan. So it would be very useful if there is a consensus from the ENT community, and teach your residents that when you put in the PET request, ask the clinical question that you need to be answered, so that the people reviewing it know what is being done. I think that would be one suggestion. And I think the Head and Neck Society and Society of Nuclear Medicine and RSNA should talk more about how to develop the EPIC guide, because the EPIC may be a double-edged thing, right? The more power you give them, the more onerous it becomes, and it may become tedious to order scans. You may say, to hell with it, I just don't want the scan, kind of a thing. So we have to be careful what we ask for, and I think we need a seat at the table when EPIC people plan how to implement these orders in. So that's something I think would be useful. I see there's a comment from Saima. To everyone. Okay, I do have another question about the report though. So you said something definitive would help. Would you mind letting us know what you feel are the implications of the words we use in our report? So for example, someone will say compatible with malignancy. Someone will say probably malignant. Someone will say possibly malignant. Someone will say cannot exclude malignancy. What do all these terms mean to you as a referring physician who's getting that report, and like, how do you make sense of it? Because there's so much variation, and I think it would help us as the reporting physicians to understand and phrase better, so that it helps you as well.
Yeah, like the point that you make with the words, it's ultimately all about semantics, right? How you converse, and those are probably, let's not get into that. But yeah, I mean, for us, as I said, PET scan is just one of the modalities, right? Now, if there is an obvious or a very high chance of a recurrence, we will always get like a CT scan or an MRI with the contrast to see what it is. And then we always would take the patient back. So for us, it's the whole picture. Okay. And you plug in the inputs of from different sources to formulate a plan. But of course, like if you do a PET scan, even if there is like possibility of malignancy kind of a report, we would then direct our focus to that area, regardless of what the report would be. Okay. Because of such a high negative predictive value of PET CT, if it's we would not go to another area to take a directed biopsy from. So if you, I mean, like this is what we do whenever we get results like these, you know.
And yeah, that was an excellent question. Very well explained, Dr. Asarkar. And I think, as you said, the standardized reporting kind of the part of it that we don't get lost in the semantics. And
So I think for the standardized reporting, if you go with NIRADS, you need a contrast enhanced CT. And so people or institutions that do practice that, they can do NIRADS, but there are certain limitations with NIRADS as well. To me personally, I think cancer is a systemic disease. It may be a local manifestation at present, but it still is mostly a systemic disease. And the problem with NIRADS or most radiological approaches to cancer imaging in general is region-based. We do a neck CT, we do a chest CT, we do an abdomen pelvis CT. That and on the other hand, you know, when you do an FDG PET scan, it's a almost a whole body scan. So for example, for NIRADS, you know, it will tell you about the primary site, and it will give you a score for that, and it will look at the nodes, and it will give you a score for the neck nodes. But what if the patient develops mediastinal disease, or what if the patient develops a new lung nodule that is very suspicious for, or multiple lung nodules randomly, you know, spaced scattered in both the lungs that are FDG avid. You know, those are definite, you know, metastatic disease unless prone otherwise kind of a category. And I think NIRADS misses that aspect of response assessment or restaging the scans. It's very local just to the neck area. Even in the neck area, I think it looks at only at primary site. If there is a new lesion that pops up in an adjacent area, you know, that's technically not considered the primary site by NIRADS. So there are issues with NIRADS, but and then a lot of places don't do a contrast enhanced CT scan of the neck with the PET scan. As the practices at LSU, they rely on PET more and get a PET scan. And if the PET is kind of iffy or raises some concern, then you get a CT scan with contrast to further clarify things. So in that situation, I think the Hopkins criteria may be a better deal, but again, the Hopkins criteria needs some modifications as well. But you know, depending on the situation, I think we as a field in nuclear medicine should make these recommendations that if a CT scan with contrast is available, use NIRADS with some modifications, and if not, then use the Hopkins criteria and have at least some standardization in your reporting things that may help. And then we could do prospective studies along the road, or even retrospective analysis of how these reports helped and better serve us. So any thoughts on that?
No, like absolutely. I echo your thoughts in terms of getting a standardized reporting and yeah, with whatever the pitfalls for NIRADS are with Hopkins. I mean, it's not a perfect tool, but still now it's a process. I think like we are getting towards being more standardized across the board. So I think we are in the right direction.
What's your take on you mentioned a lot of papers with SUV. And then you also commented on the SUV conundrum and all that. How much value do you put on SUV at the initial time point when the scan is done for initial treatment strategy, and then down the road for change? I know you made a comment that you like to do the scans at the same center so that the error is negated, but just in general, how much emphasis do you, so suppose a report comes from you have an outside consult. The patient had a PET scan in a rural or suburban center, mobile PET CT that goes there once a week, is read by some teleradiologist somewhere. It says hypermetabolic neck mass with SUV of 4. What does that mean to you?
So yeah, and as I said, I think we have to like consider all other investigation at the same time and the clinical picture, what they are showing. Another point though, and I think I did not make that, and an important point is the post-treatment or a recurrent disease. Mm-hmm. And what is a recurrent disease versus a second primary? Now, there are certain papers, and in certain cases, we look for, hey, what the SUV max was before the treatment. And now there is another disease like, say, 2 years down the line. So whether it is a recurrence or is it like a new primary? So in those cases, sometimes the values, I've had these discussions with the radiation oncologist as well, like kind of gives you an idea. Again, it's not a foolproof process or a foolproof explanation that's a second primary for sure, but that could be one aspect where, again, SUV max kind of helps you, or at least gives you an idea as to what it is. Your thought process starts in that direction.
But as you pointed out, SUV is affected by a lot of factors, and all these papers touting an SUV cutoff of this or that, they were kind of done several years back, and I believe most of those. So SUV can be affected by a lot of things that are not under our control, like patient body weight change or dose infiltration, or uptake time is under semi-control, like especially if the patient is later in the day, and if the prior patient gets delayed, then this patient may get delayed. So instead of 60 minutes, it might be 90 minutes or 110 minutes or whatever. That is sometimes controllable, sometimes not. But another thing that a lot of people don't consider is it's also affected by the type of scanner. Mm-hmm. So, long time back, pre-2005, we had standalone PET only scanners. Then we went to PET CT. Then we went to PET CT with time of flight. Then we have, proprietary algorithms like GE Clear. And the most recent kid on the block is like digital PET CT. And all those things, all those scanners have different SUVs sometimes. Like, so the difference between standard FDG PET reconstruction and digital PET may be like 3 times the SUV. It might change from 2 to 6 for the same lesion in the same patient for the same scan. So in the literature, all the SUVs, they need to tell, like, there is information about what type of scanner was used for that. And most of those are standard reprocessing, standard processing of SUV. It's not time of flight data. It is not, Q-Clear or digital. Even in digital PET, there are now like different algorithms like DLP and hyper DLP and DLR, DPR, those kinds of things, DLR and DPR. And those things affect the SUV. And so the current SUVs that we are reporting in the reports are majority of times time of flight or now Q-Clear or digital PET. But in the literature, they are older PET scanners with regular reconstruction algorithms. And so that again is another issue with the we just rely on old data and we haven't renewed the data, kind of a thing. So that needs, and so I think that's why personally I think we, at least for response assessment, we need to move away from absolute SUVs to more to a ratio to a standard organ in the body like mediastinal blood pool or liver. For the initial treatment strategy, yes, the absolute SUV has some significance because it is known to correlate with the aggressiveness of the tumor, because it correlates directly to Ki-67 value on PATH, which is a marker of cell proliferation. But I think going forward, we, in addition to the standardized response-based criteria, I think giving some ratios might be useful as well. And those are studies I think that can be easily done down the road.
Yeah, I agree. And then the other aspect for that is that we get referrals from, say, physicians who are following these patients and getting these PET scans with, say, the SUV max is like 4 or 5. And for some other reason that they have had, as you said, some reason that the SUV max is higher for the reasons that you explained, and then the patient has to maybe undergo these unnecessary biopsies or get unnecessary scans.
Yeah.
So I think some standardization, as you mentioned there, could help as well.
I see Ishani has her hand up. Go ahead, Ishani. You can unmute yourself.
Hi, good morning, everyone. Excellent lecture, Dr. Asarkar. I have a couple of questions. First question, I think partly Amol tried to answer that one. At your place, do you give CT IV contrast for PET CT part and repeat the CT part in head and neck position the way CT neck is done, or no?
No, I think they don't do a contrast enhanced part.
They don't do contrast enhanced. Then I assume that they do the CT neck as generalized position, because there could be kind of, an error, because we used to give CT IV contrast and then insurance stopped paying us for that one. So we do PET CT as part of just generalized general body PET CT position. We do not acquire. We process it in differently in CT neck, like a 250 field of view separately, and use the same data for fusion, like part of it. But we do not reposition CT neck. So that there is an error for that one. Second one I have regarding occasionally, I should not say occasionally, often we see this one, that SUV in one of this lymph node, post-treatment cases, it's equivocal, basically in terms of like 2.3, 2.4, and liver average is 2.2. We think generally this is an inflammation, and we ask them to repeat the PET CT in 3 to 6 months. Depending if patient is asymptomatic and obviously previous staging and et cetera. But how do you handle these kind of cases at your place?
Yeah, it's pretty much similar. I mean, it again, as I said, it all depends on that particular case. But one way also is doing like a fine needle aspiration biopsy of that lymph node. If it's like a sub-centimeter lymph node, then certainly we would maybe watch more often. Then I would be okay to watch a sub-centimeter lymph node with an equivocal uptake. Anything more than that, I would at least get a fine needle biopsy. And if that is negative, then I can certainly follow up with a PET scan 3 to 6 months down the line, or a CT.
Okay, thank you.
I think, Ishani, what they do is they have regular tumor boards, and they present most cases that have something positive at their tumor boards, which is multidisciplinary, and depending on the overall clinical suspicion, clinically CT, nuclear medicine, PET, and all that, they decide whether to watch or get an FNA kind of a thing. I think a lot of institutions are moving and presenting a lot more cases at tumor boards than just the challenging ones. Is that a fair statement, Dr. Asarkar?
Yeah, that's correct. Like,
Yep.
That's pretty much. It's more of consensus, right? Like, because even all that we talked today, all with the guidelines and everything, it doesn't like fit for every patient. So
Yeah.
even though we have the NCCN guidelines, still we sometimes correctly deviate from them. And this is that is the more of a consensus statement, where all these specialties are together to come together of what's best for the patient. So yeah.
Got it. Thank you.
Any other questions? I think Saima asked something in the chat about using other tracers like FAPI in a head and neck cancer. I don't. Are you guys doing anything like that at Shreveport?
Not to my knowledge, no.
Yeah, I think they when I was there many years ago, we've done a few FLT scans there, but nothing more recently. I see Euro is on the audience. I would like his thoughts on how the practice there in California is. Euro, can you unmute yourself? I guess he's not. I was just curious. So you've been at the VA as well, Dr. Asarkar, and LSU, which is academic center. Any thoughts on how the services or practices differ between VA and academic center? I was more interested in a community practice setup and academic center, but even the VA and academic center may have some differences. Any comments on that?
So I think it's not as different because our VA is still an academic VA. So
Okay.
we still have the reporting and we still have our tumor boards. So yeah, I mean, even though there are two different personnel, we still like, it's all evidence-based. So I think it's more standardized as well.
Perfect. Any questions from the audience? If not, I think we are going to end the session. So going one, going twice, going thrice. All right, Saima, you want to conclude the session?
Yeah, I would like to thank Dr. Asarkar once again for his time and providing us with this excellent talk. And I would like to thank the audience as well for being here for the presentation. We'll see you next month in September. And the upcoming speaker is Dr. Vital Savar, and I'll share more details as I finalize them. Thank you and have a great weekend.
Thank you.
Thank
Thank you
you.
for having me.
Bye.
Bye.
Bye.